With that, let's turn over to yet another department. No, that's fine. We want to make sure we got last but not least, just alphabetically, right? We'll turn it over to Aaron Egan from the VA. Thanks.
I always feel like I have to do the disclaimer at the beginning of these, since I am in a suit and I do work for Veterans Affairs in Washington, that I actually am a nurse by background. This is my 20th year, and I am based in Gainesville, Florida, and continue to practice in the community. So although I appear to be a suit from Washington, what I really want to talk to you about today is that perspective. And the first few slides here I'm going to move through kind of quickly because it's some of the legalese stuff, and I will just, they're in there. If you want information, great. Otherwise, I'll tell you what's important about it and we'll move on. Really for us, when we talk about medical countermeasures, it is a question of perspective. If you're having a conversation with a suit from Washington, the question is, what can the VA do as a federal agency? That question really is kind of irrelevant to you at the community level. And that is because really what we're talking about, and I was very surprised to see this is actually our VA hospital in Washington, D.C. It looked way nicer than I thought it would, because I've heard horror stories about it. Nice photography with the flowers in the foreground and everything. Yeah. So really for VA, VA is the federal agency. We have Veterans Benefits Administration and Veterans Cemetery Administration and Veterans Health Administration. But in reality, what we are is the country's biggest healthcare system. Almost all of you have some level of VA facility in your community, whether it's a community-based outpatient clinic, or it's a VA hospital, or it's a benefits office. VA has a very wide footprint, primarily around healthcare. The healthcare component is important when we come back to that perspective and some of the things that we can do and we can't do and some of the confusion, and I'll explain why more in a little bit here. So we're big. We've got about 280,000 employees, obviously lots of physicians, lots of nurses. I don't do physical therapists in there. I think we should, because we've got a ton of those. We have a huge push right now to hire something like 12,000 additional mental health personnel to deal with the burden of PTSD and returning troops. So lots and lots of employees. Ooh, legal framework. No snoring yet. So, all right, why is this important? This is really only important, and both of these slides are up here. My colleagues have already talked about some of this stuff, the executive order, national response framework. Really, this is only important because if we're having that perspective as what can we do as a federal agency, it's driven by this. Our congressional appropriations are specific to providing care to veterans. So when you guys come to us and say, hey, can you do a closed pod and take care of your people? That's a little tough definition, but some of those people, many of those people are not veterans. So we immediately run into an issue around the color of money. The legal framework here is what gets us around that. The Stafford Act Declaration, the National Response Framework, the FEMA CONOPS helps us with that. What you need to know is in red, okay, is if you want to talk to your local VA facility, the answer lies in our regional councils. We were successful last year in taking an aerosolized anthrax attack scenario, sending that to my general counsel in Washington, who the deputy counsel happens to be a nurse as well. It's my preference. Nurses seem to have a good perspective on these things. She was nice enough to review it, review the legal framework, and actually put out a guidance document to all the regional councils that says, this is what you can agree to in a plan. For us, it really comes down to, DoD has kind of the same thing. When something bad happens, our facility directors in general are going to do what's right. DeKalb is here. A couple winters ago, Atlanta had just an absolute blizzard. It shut the city down for a week. Technically, that facility director can't house staff members or family members of staff, can't feed them, because those are all resources that are supposed to go to veterans. But the reality is, when that happened, the facility director looked around and said, well, if I want my staff to come to work, I need to take care of the kids, I need to feed them, I need to house them. They did what was right. I've yet to see an incident, small kind of local level incident where VA didn't step up and do what was right. It gets way more complicated though when you are talking about doing medical countermeasures and planning in advance. And this is where we're really vulnerable. Now, one of my side jobs has become chairing our All Hazards Emergency Cash Program. Are there any news media in the room?
Not that I take.
Yeah, I am being taped.
We will edit.
We may need to edit this part. You'll notice it says for official use only on the bottom, so that means we're probably not. I'm going to push the boundaries a little bit, because I think our cash program is one of the areas of confusion that creates vulnerability for us as a VA facility. It creates vulnerability for you because there's really poor understanding about what our cash program is and what it isn't. That's true in my VAs just as much as it's true with you. So really, what is it? Well, if you remember, we're primarily a healthcare system. So our hospitals generally have all hazards caches that are broadly based, and their contents are, they're the things that, let me skip to this, they're the things you think about for any type of large event. So antibiotics, antivirals, medications, IV fluids, wound care, PPE, that's almost not worth mentioning because there's just not much there. So they're the same type of cache that you would think any well-prepared hospital would have. Your ER has a chem pack cart, probably. So it's those types of things. They're really designed, and if you read the second point here, these bullets are actually formally out of the policy that governs our cash program. This is the fun part of being a Fed. It's like all of these had to be vetted through our attorneys and approved through the secretary. So these are all approved things to say. Others that may present for care at the local VA medical center. That sounds great, but I think that's probably caused more confusion than anything. They're really short-term caches, particularly in large events. And I'll be specific here. If we talk about an anthrax event, my anthrax countermeasures in my facility level caches are approximately what you would think you would want to have to take care of the people in the facility on a given day. Provide a 10-day course to all the staff that's there, the outpatients that are there, the families that are there, to get us started. Period. They're not anything more than that. And if you get nothing else out of my comments today, please understand that VA needs you when we talk about large-scale events and the SNS assets that are coming into you just like anybody else does. We do not have a special arrangement with SNS, despite some of my leadership's best efforts otherwise, to receive SNS supply directly. We have to work with you to be part of the SNS plan, just like any other hospital in your community. We haven't done a very good job on that, but we're making some progress. That covers that. All right, so for large-scale events, anthrax event, we've got an issue there. What is potentially an area where we can help you is in smaller events? And I thought about, how do I give you an idea of what's in there without getting fired? And I thought probably the easiest way to do that is to use an example. So we have an all hazards cache, but we don't have all hazards capability. And I've been harping on this issue, and I'll show you a slide in a second about capacity versus capability. Capacity means I have a bunch of stuff there. Capability is, can I actually use it? Well, if we look at the Boston bombings, okay, we have several VA medical centers in the Boston area. To my knowledge, we didn't take any patients. We're not a trauma center. Our ERs are, we can take care of a mass casualty, but we're more used to taking care of, 80-year-olds with chest pain and COPD exacerbations and kind of our patient population. But yet, we have things in our cache that are designed for mass casualties. We have a lot of IV fluids that would be used for burn victims. So there are things that we stockpile at our facilities that we probably are not going to use. We're not going to see those patients. They're more than, if I have enough in my cash to take care of 50 burn patients, but my facilities don't typically have a burn unit, then that's capability that could be used within the community. So it's a conversation to have with your local VAs about what are the resources that they can share. Now, I will tell you, they are not supposed to. I hope they ignore it. They ignore a lot of what we say out of Washington. So they're not supposed to tell you specifically what we have in our cash or how much it is. We're working on changing that, but it's the way our policy is written right now. So back to perspective. So this is out of the FEMA CONOPS that grew out of Executive Order 13527 about what is VA as a federal agency going to do. It's written in Washingtonese, as many things are that we do. And I'll tell you right now that I don't know that we're going to do several of these things, but they're on the table. The first one is really about would the VA, what is this? About would we do a closed pod for other federal employees? Sure, maybe. Anybody in any jurisdiction talk to their VA about doing that in any meaningful way? Oh, somebody talked to them. That's good.
Well, from Atlanta, so changing.
Yeah, I thought that was you back there. And we'll get to why this is a maybe in a second. But it goes back to that whole conversation about healthcare system. We're a functioning healthcare system. So if we're going perspective as federal agency, we can't fundamentally interfere with taking care of the patients that are already in our system, that are going to come into our hospital, that are going to show up when something bad happens. So resources are a bit of an issue here. The second one, maintain a pre-deployed cache, that probably went back to this little bit of back and forth that some of my leadership has had with some of the SNS leadership. That seems to have been settled. We have our own cache. We are not pre-deploying SNS caches. I think that's a very good idea because I think we have enough issues with our own caches without trying to pre-deploy. But we can use the supply that we have to take care of the people that we've agreed to. That supply is small, as I said, but we can do that. And then this one is really the one that I think people have gotten a little hung up on. It is an important difference between VA and DoD. VA, as a healthcare system, the bulk of our employees are obligated to provide healthcare. So asking us to provide staffing to your open pods in your community, you can have the conversation, but I'll tell you right now, I don't think it's going to work. We're going to have to staff our own pods in the middle of a crisis where we would expect that we're going to be down significantly on nurses, on physicians, on everything else. So it's there, and people have gotten kind of hung up on, what resources can we bring in? Can you provide 50 nurses to go staff a pod locally? We can't necessarily provide 50 nurses to staff our own ICUs and floors, let alone do a pod. So it's not something that we've spent a lot of time on. What we can do is we're part of the NBMS system, and we've got DEMS teams that are stood up. But in these really short timeline events, when you're trying to do medical countermeasures in 48 hours, I don't know that that's going to be a significant answer for people because the timeline is just too short. If they're not already in your community, trying to get them into your community to put pills in people's mouths in the 48-hour or less window that you have to do it, probably not that effective. And then the last one, we're going to provide support to ESF8. I love it when we put this in things because it has absolutely no real meaning whatsoever. As an agency, it basically means that HHS or somebody else asked us to do something after you guys asked your governor for federal. So like 6 days later, eventually we would get asked to do something and we will agree to do it, but it's not particularly helpful. What can we do from the local perspective? Well, I already said the facility directors, although we are a federal agency, our facilities are very much independent. They are free to ignore pretty much anything we tell them to do out of Washington. It's quite It's been very interesting. But they can basically do what they think is right. And historically, VA facility directors have done this. There is not typically pushback, at least at the time. It may be career limiting for them down the road, but at the time, it's supported and it happens. This next one is the one that, you know, I'm a nurse, I've done this a long time. The devil is in the details. So if you've had a conversation with your VA, okay, how many of you have VA come to your planning meetings? Okay, a couple. My emails at the beginning of this presentation, by the way, if you want help or have questions with your local VA, please reach out to me. We typically will come to meetings and we will say, yes, we're going to take care of our own. I'll tell you right now, our facilities have no idea what that means when we talk about medical countermeasures. We have done 0 functional exercises about how do we actually use the antibiotics in our cache. There are details about how our antibiotics are cached that I can't functionally find solutions for right now. So if the bad day event happened and the VA says we're going to take care of our own, I'll tell you right now, we don't take care of kids. We're not real good with pregnant women. Okay? There's some huge functional issues that we really need you guys to teach us how do we sort this out. Okay? Because as a parent, as a husband, as a nurse, I'll tell you right now, if you want me to show up to work, you better be taking care of my family. You better not tell me that, oh yeah, I can come to work and I'll get my Cipro, but my wife and kid have to go stand in line in an open pod for 6 hours and risk a riot. Get that. But we don't know how to do that yet. We're starting to make some progress. We can execute agreements to participate in closed pods. If you go talk to your VA and tell them that, they may or may not understand that. That's why your key is your regional council. Okay? One of the things that happened after the executive order, and we touched on this, there was a memo that came out last year from GSA. GSA that said, oh, GSA is looking at serving at closed pods, and it actually mentioned VA in there. I'm still not sure how that happened because nobody in VA that I can find out about knows who said that. It was a blanket statement. It has caused anarchy in VA to the point where one entire region, okay, my southern region, my home region, has literally circulated emails around for the last year that the punchline of the email was, oh, VACO, which is Washington in VA terms, doesn't want us to participate in planning with local public health, so ignore that. We're not supposed to do anything. So there's a huge amount of confusion on our side of the street. We're getting there, but don't be surprised if you get a blank look and get a, no, we can't. Yes, we can. We just don't necessarily know it yet. The last one is the point I just made. Please engage us too in real-world exercises. I've worked with our folks in Chicago some. I attended a very nice tabletop that we did there with Chicago Local Public Health. The VA facilities had great participation. We had probably 300 or 400 VA staff from the various facilities there at that tabletop exercise. But our idea of an anthrax tabletop exercise was like somebody sent a letter to our mail room, so we had like 30 people potentially exposed. The concept of an aerosolized anthrax attack is really tough for people. I put together a set of slides. I looked at the UASI Tier 1 cities and had, thank God I've got a GIS guy who knows how to look at all the data. I had him plot for me the veteran population density in the metropolitan areas, and it's anywhere from 6 to 14% of the population in those Tier 1 cities. So even at 6% in Chicago, if you take the main planning scenario, 330,000 people exposed, that means something like 20,000 of those people are veterans. That really helped resonate for me in Washington when I had this conversation with my leadership that saying we're going to take care of our own doesn't work. Our own are part of your communities are part of our patient population. With these large events, it's all together. And if we continue to pursue the silo that we do now, then we're going to completely fail to be able to take care of our own if we don't recognize that that's not, in a large-scale event, that's not a reasonable goal. So, what are we doing right now? We finally, Lisa was very happy about this, about 3 weeks ago, had a bit of a come to Jesus conversation with some of our leadership and got them to recognize that we really need to clarify for our facilities that they need to reach out to you guys. I think DOD was saying, they need to reach out to you. They need to figure out how you guys are planning on doing medical countermeasures and align with that. Not plan on doing something different. That's all you need is you guys have a whole plan set up and you've got your VA. VA's giving out 60 days of Cipro and Doxy and you're doing 10 days from an SNS pushpad. Then you've got a riot on your hands. We don't need that. You don't need that. We need to start working through those things. That will come out. Since we're a federal agency, God only knows when that will come out, but we'll see. We really need to get them working, and then we need to integrate with you guys and play together. We're at a point now where we've got relationships. I think most of you could reasonably find out who the emergency manager was at your VA facility. Hopefully you have some level of relationship there. I know that's not true across the board, but now we need to actually get to the details for these large events, because picking up the phone and saying, hey buddy, we've got an anthrax attack, you guys are going to take care of your own now, right? At the time of the event isn't going to help us. And then hopefully, since you have such a beautiful guidebook in front of you that lays a lot of this out, we're going to work with NACCHO. Andy's not here, but I think he knows this. We're still trying to figure out how we do this, but work with NACCHO to put together a guidebook, much like the DOD guidebook. And in this case, that guidebook would be at least as much for my own facilities as it would be for you, but lays out some of these things. We've also put together, anybody here from Pennsylvania? No. So Pennsylvania's got a template MOU for the state that somebody sent to me that actually does a really good job laying out some more of the specific details. So our general counsel's office, Lisa, this is for you, I saved one for you, is reviewing that right now for me, and I hope to have back a template for our VA facilities. Because I will tell you, very few of my facilities, right now there's about 5 out of 152 that I'm aware of that have signed an MOU, and they're all over the place. I have one that has a signed MOU, and it says we're going to take care of our employees and our families, but doesn't actually mention that we're going to take care of veterans. I'm thinking Congress is going to be a little cranky about that one if they get wind of that. They don't go to the level of okay, what does that actually mean? How do you then tell local public health how many people that is? And saying we're going to take care of our own, as I mentioned, in Chicago, that means you got a plan to take care of 20,000 veterans, their families, all your employees, all of their family members, maybe other federal employees in a closed pod. That is far beyond any reasonable capability we're going to have. Plus, we're a functioning medical center. So I really don't know that it's a great idea for us to try and do pods on the grounds of a functioning medical center. You guys are the ones putting plans in place. I'm curious, do your hospitals normally serve as closed pods for large groups, or are they really just taking care of a core? Because I just think about an ex-ER nurse, having 5,000 people standing outside the ER of the hospital wanting their pills as you're trying to get chest pain and trauma in and everything else. Seems like it might be a bad idea. We haven't even started to broach the subject of where do we do pods. And finally, remember, we're part of your community. We don't always do a good job remembering this, but that's how you should approach us. We're part of the community. The other trick is don't come to your local VA and ask them what they're going to do. They don't know. They flat out do not know. If I ask that in Washington, we don't know either, but certainly at the local level, they do not know. So go to them and say, This is how the community, DeKalb, has done a good job of this. It's been a rocky road. This is how the community is set up to respond. We're doing open pods for the community. We're asking large employers to set up closed pods and take care of your own, and this is what that means. This is how you define those people, and we would like you to agree to participate as a closed pod. That's going to get you much farther than going to them and saying, what are you guys going to do? Because all you're going to get there is we're going to take care of our own, and it's not defined at all. And then, since this is mainly large stuff and medical countermeasures, it can be a bit of a two-way street. If it's smaller events, build that relationship with the VA, because in that case, we do have resources that can probably help you out. And we can use them for that. What exactly those are really depends on the situation, and how those are used gets a little tricky, but reach out to us and ask.
Thank you, Aaron. And with that, we will turn it over to Beverly Pritchett, who will walk us through the wonderful guide that sits before you and some of the observations that she had during this project working with NACCHO. So we talked VA, CDC, DOD, and now we're going to talk locals. So with that, the floor is yours.
Well, good morning. And first of all, I should clarify probably what my background is. I haven't spent my entire life doing consulting. NACCHO hired me to do this guide because I'm a retired medical service corps officer from the United States Army, spent 27 years doing things like commanding hospitals in deployed situations, Bosnia and Iraq. I then went to work for the DC Department of Health and was the FEP director there for 5.5 years. So I have that background also, and I'm a disabled vet, so I also have the experience, particularly in the DC area. Aaron, I would say that one thing that I think that the VA integration with this type of program is going to be location specific, and how the planning goes. DOD is a little bit different because they do have their own installations where people have to report into. But obviously the vets don't necessarily have to go to the VA, and in places like Washington, DC, Chicago, LA, and New York City, the big cities that I'm most familiar with, working with, getting to the VA is probably going to mean crossing tons of jurisdictional lines, and that would probably be best not just going to their local open pod.
I did the same thing I did.
And from here on out, from
so the guide is an evolving process. Many of these slides are things that people have already gone over. Executive order is out there. That's what started this whole process. The interesting thing is that in the second week of November in 2010, I received a phone call from Mike Staley, who was our coordinator for CDC and the SNS program. And he said, DOD is reaching out to us and wants to meet with some of the big cities, and they'd like to do it in 2 weeks from now. Do you think you could pull together your entire group of emergency responders that you normally work with so that they can meet with y'all? And I said, well, what exactly are they looking for? And they said, well, they really don't understand this whole process of closed pods and what your response level is going to be and what's necessary. So 2 weeks later, they showed up and they came out with us in DC, and then they went to Chicago and LA, and New York City was not able to pull all of their group of people together. Obviously, much larger city, a lot more problems trying to get all that done. But they did meet with us, and it was some very interesting meetings because although I had worked very closely with our local DOD installations because I had just retired from one of them and knew all the people there, it was very easy to talk with them, and they were incorporated in all our planning. I didn't realize that big DOD at the health affairs level really and Northcom really didn't have a good understanding of how the response was supposed to go. So in July of 2011, then the Secretary of Defense began these really high-level meetings with HHS, and DHS and NACCHO was there. NACCHO was at every one of the meetings too with with the big cities folks. And the results of all of this was this White House memorandum about medical countermeasures, dispensing and distribution, which then resulted in this commander's estimate that you already heard about. So DOD then published this DISCA guide, which is in your guide, a copy of it, and on the guide itself, it tells you where to find it on the website, so you can download your own copy of it too. So DOD is doing this DISCA support. At the same time, we're trying to get with them on how to do this post-pod planning. So it was a perfect alignment. Here's the picture of the front of the DISCA guide, and then the backside it's a trifold that holds up very nicely. And it goes through all the basic things, explanations about how we would interact with the Department of Defense in this, the typical, you have to go through your emergency manager, which you've got to go through the governor or the state governor, over to FEMA and all of that stuff. Things out that emergency managers are normally familiar with, but all at the local health department level, they may not be familiar with the federal side to that. So then in April 2012, NACCHO contacted me and said, hey, we'd like to do this guide. You kind of have this background and experience, and aren't you doing consulting work? Why don't you help us out with that? And so I did, and we got together a group of people that had already done some very successful closed pod MOUs, and we published this guide in May of this year. We do want to point out that it says down in the bottom left-hand corner of the front cover, FOU, and that's because there is one of the slides, one of the pages in the document, the C. Burney slide, and that's the only page in the document that's actually technically FOU, but in conjunction with the way you're supposed to do labeling, it is on the front, and so you just need to know that it's kind of a little difficult to see, but I do want to make sure that you know that that's not supposed to just be handed out to anybody. It is supposed to be kept within your government guidelines. And that's a picture of the cover of the guide. So the guide is now found on the NACCHO website. All the references should also be posted there along with the guide. Because it took a little bit to track down a couple of the references that are noted there, if you actually want to sit down and read all the background references, they are located there for you. The guide contains a listing of those. It then also talks about the layers of military support, and that's that immediate response, the MOUs, and when you get to the Stafford Act declarations, how those types of forces can be laid out. The subverting forces is that, that kind of third line of defense when you've gotten to the point where you've gone through all your state and local resources, your immediate response is done, and kind of mutual aid you set up is done, and then these subverting forces come in. And with discussions with Northcom as we were going through this, there is a small element of the subverting forces that can get there pretty quickly. They're not going to do a whole lot for the pod aspect, but all the rest of the stuff that you have to do after an anthrax incident, they are certainly there to help, and they have tons of capability. So surveying the area, those kinds of things, your civil support teams and your National Guard, all of those people are readily available to help. They're not going to get there. They're probably not going to be there for those first 12 hours, though, when you really need to be getting your pods up and running. The guide also contains a trifold and then a sample MOU. Now, I will tell you that I heard this morning that there's a complaint that the MOU was maybe a bit long. The version that we used in DC is a shorter version than this, but it's a compilation of all the things that people thought were the best parts of the MOUs in their jurisdictions that were actually signed by DoD facilities. And I know the longer that a guide is, the more difficult it is to get through legal channels because they want to review every word of the MOU. So feel free to strike out the pieces that you don't think are very helpful, but there were pieces that I thought we should have included in the version that we use in DC, but we hadn't thought about it. So this is just kind of a compilation of best practices. So there's a couple of things that I wanted to tell you. just kind of comments after listening to everything everyone has said today is that, first of all, there are success stories out there. Quantico Marine Corps Base in Virginia has a successfully signed agreement. We've had one with Joint Base Anacostia in DC, which used to be known as Bowling Air Force Base. The good thing about getting somebody to sign an MOU for a joint base is that that means you've probably picked up more than one installation at a time. The way the installations work these days, if they're in a vicinity of each other, you can get more than one installation, and you don't have to go, like Joint Base Anacostia is like a piece Navy, it's a piece Air Force, and a piece, I'm not even sure what the other piece is, but it's a three-part thing, and instead of having to go through all three of the different major commands on the installation, we got one to go through and sign. The other thing is that not all commanders are created equal, and so, and I can say that because I was commander, so I know that. You can be a commander of base forces, so you have some type of troop support organization, and that's not the kind of person you want to get to sign this type of MOU. You either want the installation commander to do so, or the health clinic, hospital facility, whatever commander to do so, because they're the people that have the authority to actually do those things on the installation. The other thing is that I've had this question. I'm working with Los Angeles County now on a very similar type of project, and they said to me, so can I go and talk to the National Guard? And it was like, well, of course you can. I mean, you don't have to go through anybody to go to the National Guard because, well, you have to figure out like how you have to go through California State. But I mean, they're a state force. So although they're DOD, they belong to your state and your governor, and you can do that direct line coordination without having to ask permission of anybody else to do so. Let's see. For your VA counterparts, if you're trying to work with your VA counterparts and you don't really know who that might be, look to your healthcare coalitions in your area. Your hospital preparedness program coordinators should know who those people are, and that's a great way to make sure that you link up with any kind of federal agency that has a clinic, because your hospital preparedness coordinators are probably already tied in with them. I'm trying to see if everybody was talking, I was making notes. Oh, and then lastly, what I was talking with David and the crew here at NACCHO, the guide went through one last pass before it was published at DOD, and I understand now that all installation commanders, before they take command, they go to an orientation course. Just about 1 week in the Army. And they're all going to be briefed on the guide as they go through their upcoming trainings. Is that true?
I just want to validate that, Dan. Is that, we're probably not stating that accurately, but go ahead.
I would say this is a piece of Lieutenant Rand, but DOD there are 10,000 hands. It hasn't crossed our desk yet, but that's not surprising because we're not directly involved in installation management and health affairs. But that would be good.
But just to be clear, is it in front of the FEOs who've taken it to that training or not? I can't. Don't worry, we'll turn the camera off this part.
My gut is that it's probably not being driven by the FEOs, but I would be very curious where the driver is coming from.
Well, maybe we'll do it. All right, anyway.
Yeah.
So those would be the two things that I would say that the courses that this should be presented at, and even if it's in an unfinished stage now, or maybe a stage to be modified, it's got some great information in it, and it does provide the guidance, so it can be a two-way set of guidance. Absolutely, installation commanders on the Army side, they do go through a 1 week program before they take command, and that's a great way for them to be educated on this too. So.
Yeah, thank you, and thank you everybody. So we're a little over, which is fine. That always happens at meetings like this. We wanted to make sure we gave you as much good information as possible from the top, the federal partners and the partners that help develop our guide.